Good afternoon, everyone. Welcome to the Utah Infection Prevention Collaborative. These sessions are here to help you better navigate through this challenging healthcare crisis. Leading the presentation today will be our infection prevention specialist, Martha Jaworski from Comagine Health. Also part of our expert panel are Dr. Alan Nakashima with Utah Department of Health HAI program. And we have Ali Spangler joining us with the Utah Healthcare Association. Nice to have you here, Ali. Just a couple of housekeeping details. Your cameras and microphones will be off during the presentation. You can go ahead and use the chat feature to submit any questions that you have at any time during the presentation. And please, when you do chat, if you could select the option to chat to all panelists and attendees so everyone can see your comments, that would be great. We'll have some pauses for a polling throughout the presentation and a question and discussion session. We can also unmute you to share when we get to that part of the session. And please note, we are recording this meeting and we'll make it available following the webinar. So why don't we go to the next slide? Okay, just a couple housekeeping details for folks that maybe are newer to Zoom. We have some attendee controls up here for you to see. If you're not familiar with the platform, you should be able to see the presentation directly on your monitor, and the camera and microphone icons on the bottom left will allow you to share your video and speak. We encourage you to enter comments and questions into chat, and to do so there's a button in the middle bottom of your screen. And if you're using your phone for audio, when the time comes, you'll be able to mute and unmute your line by hitting *6 on your phone keypad. We also ask that you link your phone and computer if you are using your audio over the phone through the directions on the screen. Next slide. A quick introduction. Comagine Health is very pleased to be bringing this to you in partnership with the Utah Department of Health. And we are the Medicare Quality Innovation Network Quality Improvement Organization for 6 states: Idaho, Nevada, New Mexico, Oregon, Utah, and Washington. We work with providers in these states and others across the healthcare spectrum to look at delivering better care and promote better health at a reduced cost. And just delighted to be with you today. Next slide. The purpose of this series is really to help you with essential infection prevention training, and we know a collaborative tends to produce better results because it's better if we can do more by working together on these challenges. Our commitment to you is to do our best to identify relevant topics, and we welcome your feedback about what's most relevant to you. Stay up to date on guidelines, provide content and a platform for peer-to-peer sharing, invite state partners to join sessions, and to listen to you and remain flexible on the content. So we began our weekly sessions with a kickoff last Wednesday, which was recorded. If you didn't receive that recording and would like to view that, I'll be glad to send that to you, and I'll put my email in chat for you to reach out to me directly, or we'll be emailing that as part of our invitation for the next session. These sessions are about 60 minutes in length, and so what we're doing is roughly about a half an hour of content, and then Q&A and discussion and announcements from some of our stakeholders. So if there are questions that you have or that this brings up as a result of the education provided, we invite you to ask the folks that are part of our panel to be any of the questions that you might have. And we'll be sharing tools and resources along the way. We are working to really create a safe space for you to share. So any polling that we do is anonymous. And if there's something that you would like to share in chat but don't want to identify yourself to the group, you could chat to me privately and I can bring it up to the rest of the group. The next slide. What we're asking of you is come to these sessions, ask your questions, be active in chat. Let us know what you're thinking. Let us know what your challenges are. We are going to do a mid-series check-in in and around sessions 6 to 8 with folks, just to see if we are hitting the mark with what you need. We did send out a little survey in advance of this series to kind of get a sense of your comfort zone with infection prevention in your buildings and the comfort zone of your staff. So we will make sure that to send you the link again, but if you haven't gotten a chance to respond to that, we'll put the survey link into chat for you. And Martha's going to give you a couple of assignments on a weekly basis to do just to, again, continue to build up your infection prevention program. So make your best effort to try to do these and share with us what you found in the next session. So next slide. This gives you a sense of what the session schedule looks like. We had a kickoff last week. Today we'll be talking about controlling respiratory outbreaks, and you can see some of the content in the other sessions. And again, I please invite you to share anything, any content, any challenges, any things, topics that are really of interest and relevant for you. We'd like to make sure that we're representing that. So if there's something that's not represented on here that you would like to see, please go ahead and chat that in and let us know. All right, and we're going to start off with a polling question. So next slide. The purpose really is, again, to make sure that what we are providing you is on point. And so we really value your feedback. So just take a moment to answer. We have a couple of polls for you. Your best thoughts. Most people with COVID illness develop symptoms between 2 to 14 days, from day of exposure to 10 days after exposure, from day of exposure to 14, and from 2 to 10 days after exposure. So we'll take a moment, about another second or two. Okay, and so Lisa should be sharing the poll results. It looks like most of you said between 2 to 14 days after an exposure. And then Lisa, do we have another poll coming up? And if you can answer, how can COVID-19 disease be spread between people? Just another 10 seconds for that response. Okay. And I think that's all the polls that we have, but Lisa, if we've got one more, is that? Is that it? Mm-hmm. Okay, next slide. All right. So I will now turn things over to Martha Jaworski, who is our infection preventionist. That's going to take us through some education. So Martha, are you there?
Thank you, Shannon. Yes, can you hear me?
Yes.
Excellent. So welcome today. I want to reiterate, if you could all put your name and your location into chat and chat to all panelists and attendees, that would be great. Looks like only a couple of people have done that. So we do want to try to, as Shannon mentioned, build discussion and build a little bit of community in this group. We want this to be, more interactive, as interactive as we can make it with using chat. So go ahead and put that in. That would be fabulous. So my name is Martha Jaworski. I've been working at Comagine Health for about 7 years, doing infection prevention related activities. And prior to that, I worked in the hospital and long-term care settings in infection prevention. And I'm also a nurse. So next slide, please. So for today, we're going to look at, I'd like also if you could put in to chat, you can start thinking about this now, what is going on with your planning for COVID-19 positive residents or staff in your facility, or if you've had some COVID-19, if you want to chat in anything about lessons learned or perhaps advice to others that may not have had a case yet. So do please use chat. And then I will also do a what's new from CDC. We try to do that every week. And then just look at some basics of COVID-19, just a few slides on that, and spend most of the time looking at chain of infection. So this is basic infection prevention, going from how do we go from host to host? What does that look like? And how do you prevent that transmission? And then I'm going to finish the last session. We had a question about what kind of evidence is there for source control. So I did want to spend a little bit of time on preventing transmission in the community, which is obviously very linked to transmission within a facility. So that's what's on today's agenda. Next slide. So last time we talked about risk assessments, and I know we have not sent the actual tool out yet, but just curious if people have thought more about risk, and again, anything about a plan for positive cases. So anything you want to put in chat about that is great, and we will discuss that. Next slide. So the CDC update, some pretty big news this last week was that there's a phase 3 clinical trial for a COVID-19 vaccine in the United States. So it's still a ways off, but this is progress. So the first two phases looked at safety, so making sure it is safe to this point, and whether it can launch any kind of an immune response. But now the plan is to distribute it to 30,000 people, I believe, and some get vaccine, some get placebo, and compare those to see, does it really protect against actually getting the disease? So that's pretty exciting, and that was a new item in CDC. Next slide. So what do we know about COVID-19? We know it's caused by a virus we've identified, and thankfully we've done that and have a test, because things would be much worse if that had not already happened. But as time goes on, the common symptoms shift, and they understand more about what the symptoms are. And these occur between 2 to 14 days after exposure. So many of you already knew that, which is great. And this is called that incubation period between when you're exposed and when you actually show symptoms. So as you can see, it has initially, if you remember, it was cough, shortness of breath, fever, and we now have quite a series of new symptoms. So one thing I'd suggest you do is check your screens and make sure that they're up to date with the new symptoms that are identified for COVID-19. Also note that fever, I believe, is defined as 100 degrees, but in an elderly population, you might want to look at trends in temperature and keep a closer eye on anyone that has a temperature trending upward. And there is a link there to that site. Next slide. Another thing that was updated fairly recently is who is most likely to get very sick from infection. So there's an increased risk of mortality by decade of life, and many of you have probably already seen that, but particularly over 80, there's a large increase in mortality rate. But other comorbidities have been updated again as we evaluate more people with the disease, and this is the most recently updated list. One thing I found interesting on this is obesity used to have a BMI of greater than 40, and they have dropped that. So that is actually a significant risk factor in and of itself. And several of these other ones probably look familiar from previous versions of this. Also to point out, long-term care residents are obviously at high risk for poor outcomes due to age and comorbidities. And we encourage you to look at advanced care planning and who has, making sure you have living wills and that people have made their wishes known prior to a crisis situation. Next slide. Treatments. I just wanted to put this slide in so people knew where you can get good up-to-date information on research going on into treatments. There's obviously no cure at this point, but there's a lot of research and a lot of new information on this National Institute of Health site. So, you know, what you're treated with is going to depend on the phase of your illness and your presentation and your symptoms, but there's a lot of new information coming out on treatments. Next slide. So this is a chain of infection, very basic infection prevention. You're going to start with, I'm using a respiratory virus as an example here. Start with an infectious agent. It has to have a reservoir and a host. So where is it living within the host? And for respiratory viruses, they're primarily in the respiratory tract. And then they have to have a way out. So it is by exhalation, coughing, sneezing, vocalization. Then you need a way to get move to the next host. So it can be droplet contact or airborne transmission. And then for a respiratory virus, you're looking at inhaling the virus or having it get in through the mucous membranes of your face. Droplets can go into your eyes, and you can also touch things and then touch your face. And then you have to be susceptible. So you have to have a person with no immunity to the disease to then become the next host. And then the cycle goes on. So what we'll do is circle back to this slide at the end and show where different interventions can help break the chain. Next slide. So how is SARS-CoV-2 or COVID-19 virus transmitted? Through droplet transmission, contact transmission, and some airborne, probably. Definitely if there is aerosol spread from aerosol-generating procedures. Next slide. So for droplet transmission, exhale droplets have been shown to stay in the air for about 6 feet from an infected person or a source. So that is why we have the 6-foot distancing rule. And there's a lot of like physics to this whole thing. If you read any studies on droplets, the size of the droplet makes a difference, and many things go into that. But that's an approximation of distance. And then the droplets are inhaled through the nose or mouth or eyes, not inhaled, but go into your eyes. And again, certain conditions can increase the risk of transmission. So of course, the amount of virus in the exhaled droplets, sneezing, coughing, singing, or shouting. There was many of you may have heard about the Washington State choir practice, where one individual that was either pre-symptomatic or asymptomatic infected, I think it was around 40 people. It was very big, but they were singing, and that is a known way to spread respiratory viruses to further distances. So environmental conditions like humidity and airflow can make a difference. If you have, for example, a fan blowing across an area, that can impact where those droplets land. And humidity, if you're in a more humid environment, in theory anyway, the droplets are more likely to will drop more quickly, because as they dehydrate and become smaller, they can radiate further out or move further out from the source. Then individual characteristics. There are super spreader events where one person appears for some reason to be very efficient at spreading the virus. So there's still a lot we don't know about how it's transmitted, but droplet is definitely a way that can happen. Next slide. So to prevent droplet transmission in a healthcare setting, you want to be wearing a face mask or a respirator and have eye protection. And that's going to be the direct hits to your face with these droplets. And then in all situations, you want to maintain at least 6 feet of distance. Obviously, in healthcare settings, you often need to be within that 6 feet. And then minimize the time near a source. And then covering your cough and source control will help prevent the droplets from ever leaving the individual. Next slide. So contact transmission is another way the virus can be spread, or anything can be spread. So kind of on a more general view of it, you can, once you touch a surface or a person, if you don't wear gloves or perform hand hygiene, you can sometimes become colonized, and we hear about this with like multi-drug resistant organisms, where you pick something up just by being exposed to it through your skin, or you can become infected by that. So for some infectious agents, more like the respiratory viruses, you typically need to bring your hands toward your face. So again, you're touching a surface near someone who's coughing or sneezing, and then you touch items, or you touch items handled by that person, and then you touch your face. Or the other thing you could do is with your hands transmit that or transfer that infectious agent to other surfaces. So really good hand hygiene is key. And so the types of surfaces you want to look at are tables, bedding, clothing, equipment, door handles, like such as call lights, TV remotes, anything you're touching frequently, phones. Next slide. So again, you have to touch a surface, and then you have to touch this notion of a T-zone, which is your two eyes, your nose, and your mouth, or not perform hand hygiene and touch other surfaces or individuals, which they then touch things and touch their face. So next slide. To prevent this, you really need a combination of very good hand hygiene, good surface disinfection, and not touching your face. And it's interesting to do the experiment of just watching people for a while and looking at how often they do touch their face. Some people touch their face a lot, others not as much. But it's important. It's an important habit to try to break if you can, although it's very difficult to do. So we do certainly encourage a lot of hand hygiene and surface disinfection. And then for personal protective equipment, gowns and gloves are the main personal protective equipment for contact transmission. However, face masks and eye protection, in addition to preventing, droplet exposure, it's a big reminder to not touch your face. If you have gloves on and a mask and goggles, you're very unlikely to touch your face. So that PPE really does help reduce that transmission. Next slide. So we're going to talk about cleaning and disinfection later, but I just wanted to put up a resource for that. This is from Leading Age in Ohio, and the pages are there. But this, I just highlighted a few key components that are maybe a little beyond what your policy might already say. But do you have dedicated medical equipment, especially for a COVID-19 patients, for sure, and for all patients or residents needing to disinfect between use? Also, it's a good time to be auditing environmental service cleaning, making sure people are really disinfecting the high-touch surfaces. And then checking your disinfectant that it's EPA approved from List N, and there is a website there you can go to. And you want to look at the actual EPA number, which is typically in very tiny print on your disinfectant, and make sure it's on that list. And then consider who is cleaning, and if you can get additional people, particularly in COVID positive rooms or units, to take on some of the cleaning activity to reduce the number of people in the room, and also to make sure those high touch surfaces are cleaned more readily. But there should also be training in how to do that. So wearing wearing gloves and the contact time and all that. But having more people involved in high touch surface cleaning is a good idea. Next slide. So for aerosol generating procedures, these are you're at high risk for spreading COVID-19. So you want additional precautions, and it is recommended that respirators or an N95 such as an N95 mask are used. And this basically what happens in these aerosol generating procedures, these respiratory droplets become, move into that airborne category, which is the very small particles that move longer distance and can be carried. So examples of aerosol generating procedures are CPAP and BiPAP. CPR and intubation, which would obviously be crisis situations in your setting, but also nebulizer treatments and high flow oxygen. And these were the ones that I thought there was a chance could happen in your organizations, but there's a longer list on that CDC FAQ. Next slide. This is an example of a sign that can be used, and just a reminder that if you don't have signage, you should definitely have signs on hand for, this is an example of a COVID-19, so kind of a droplet contact combination, which includes the eye protection. So that's a nice one. This is from Washington State. But what you need to do for transmission, preventing transmission with known or suspected COVID-19, you need a single room with the door closed and personal protective equipment. The recommendation is that N95 mask or respirator, but you can use a face mask if you don't have respirators. And I think, yeah, there's just a question that came up in chat. If people want to type in whether you're using N95 masks, and if so, yeah, if they've been fit tested. I see we're getting some results, some comments there. So we will circle back to that for sure. And then you need eye protection. And this is glasses, like corrective lenses do not count for this. So you need medical goggles or a face shield, gloves, and a gown. Next slide. So aerosol generating procedure recommendations, it is a negative pressure room, which I am fairly confident none of you have. But if you do, that's the best place to do any aerosol generating procedures. But you can also close the door to the room. You want the minimum number of staff in there, and you're going to wear gown, gloves, eye protection, and the respirator. So for these procedures, they really don't even say you can use a face mask. They really want you to be using that respirator. Next slide. So this is where I want to talk a little bit about preventing transmission in community settings. So this is outside of personal protective equipment inside your facility. But I would say that there is community possibility even within your building. So people that are, at a reception desk, for example, they're not directly working with residents, but they have contact with them. So this idea of source control, it's again preventing the droplets. And I want to point out that this is really in alignment with covering your cough. So it's like covering your cough all the time when you're out in public. And as I point out, it's urgent due to pre-symptomatic and asymptomatic individuals that can transmit without even being sick. And then, of course, physical distancing and limiting time exposure. So I used to work in a radiation research lab, and it's all about time, distance, and dose. And it's really very similar with respiratory virus spreading. So you want to always be thinking about keeping your distance from people, minimizing your time with people. And then the dose, of course, we have a lot less control over, but wearing a face covering helps reduce the dose that is being expelled out into the air. In addition, dose can be, if you can get a rapid dilution of viral particles, like in the outdoors, that helps with that third component as well. Next slide. So I'm just going to talk a little bit about rationale for cloth face coverings. And so it's based on three premises. One is that there are asymptomatic carriers. The second is that they can transmit the virus. So basically and of course the third implication is that almost everyone is susceptible. So we're really living in a time when you just don't know who could be able to transmit this. And so the cloth face coverings help prevent the exhaled viral particles. I repeated that several times, I know. But the recommendation, this is from CDC, that's their rationale for why. Next slide. So I'm going to just start with the first premise: can asymptomatic individuals spread COVID disease to others? So there was a review of several studies that support asymptomatic spread. And they basically, what they looked at was, especially early in the pandemic, I think the first case in Germany, in fact, was one of the examples in there. There was one person who had lunch with one person from China, and that person had no symptoms for several days after that meeting. And it was very clear when there's no community spread yet. There were several studies along those lines very early that showed, yeah, these people can transmit way before they're symptomatic or when they never become symptomatic. And then they also look at viral load in asymptomatic versus symptomatic people and show that it's similar. So the ability to spread is probably there. And then they did modeling studies also to show that, it doesn't appear possible that this could have happened from only this one symptomatic person, that type of study. And then the next question is, how common is asymptomatic infection? And I've seen written 25 to 50% as a estimate of all people that are infected. And so this was a summary of this. What I have here is a summary of 16 studies, and these were all exposure studies. So as you can see, there were a couple of cruise ships with known exposure with a defined population, and that's what these studies all are. So it's not saying that this percent of the population has asymptomatic disease. It's saying that within these exposed groups. So I just highlighted the numbers that are between 30 and 65. So this study kind of confirmed that estimate that there are probably many people that are able to spread that are never symptomatic. Next slide. So are cloth masks effective? So one study looking at that question looked at state mandates and then the resulting impact on rate of new cases. It showed that there was a statistically significant decrease in the rate of new cases after mandates went into effect. So that was one piece of evidence. A healthcare system that required face masks and saw a reduction in healthcare worker infections. In this more recent study or incident in a hair salon in Missouri, which had universal masking practices, and they had two stylists. One stylist A became symptomatic and continued to work, and stylist B contracted it, likely from him or her, and then their clients, between them, they had 139 clients that were likely treated at the time they were shedding virus, and 67 were tested. They were all negative, and they followed symptoms on the rest of them, and no other cases were ever reported. So that's a really nice little study of universal masking practice. And these, it's hard to cut hair within 6 feet, being 6 feet away from someone. So these are fairly close contacts for, a longer period of time. So that's a fairly compelling case in support of masks. And these types of mandates don't require they be a surgical mask or anything like that. It's just you've got to cover your nose and mouth when you come in. Next slide. I also want to talk a little bit about numbers. This idea this is a reconstruction of what was presented at the Johns Hopkins contact tracing course. And it's to point out when you've got something like COVID-19 where one person overall, in general, infects more than one other person, you get that logarithmic increase in cases that we've all seen. So this is just a visual of what it means when an intervention is 50% effective for this type of transmission. So on the left, it shows no intervention at all, which of course right now in August of 2020, every place has some level of intervention, right? Nobody's acting exactly like they did a year ago. But if you look at just one intervention that's 50% effective, you can see on the right, the first person only transmits to one of the two, or 50% that they would have. And then the second person, again, only transmits to 50%. And then that person, again, to 50%. So you can see on the left, one person transmits to 14, results in a transmission to 14 people. And on the right side, one person results in the transmission to 3 people. So it's a nice visual of what it means to be not 100% effective as an intervention. So I guess my point here is that you shouldn't dismiss things that are not 100% effective, because any improvement in transmission risk or reduction in transmission risk is going to be more effective when you look at it from that reducing the logarithmic scale of what's happening now. Next slide. So if you, it's thought that often in long-term care settings, staff members are bringing COVID-19 in, obviously inadvertently, perhaps without symptoms. But if you, this is just again from the Minnesota State toolkit, some actions staff can take both at work and outside of work. Next slide. And then there's a series of videos from CDC that are very good they would be great for staff and resident education. One of them is Keep COVID-19 Out, and that has some good, very quick information on how to use the mask correctly, how to social distance, and done in a very nice way. I think they're between about 5 and 10 minutes, most of them. So I have them all as resources at the end here. Next slide. So going back to our original chain of infection, you can see source control is acting at stopping it before it can get out into the air. And that's a very effective way to reduce transmission. So covering your cough, face masks, cloth face coverings are all at kind of that, how is it exiting the person? When you get to a resident, let's say in a room with no face covering, when you go in, you're trying to prevent what's in the air and on surfaces to prevent your becoming infected. And that's a little more difficult to do, actually, but that's why we have face masks, gloves, use hand hygiene and disinfection. It's kind of at this point. And then, of course, a vaccine, which is what we're all hoping and waiting for, is going to reduce our number of susceptible hosts. So that's where that's going to act. Next slide. So here are several resources. some resident education. There's also staff education. We can also provide some policies for you if you, haven't seen if people have been, you know, what they've posted on whether you have policies and posters, but we'll be sending out some policies, sample policies. And next slide. And these are the 4 CDC videos on staff and resident education. So there's a nice one on hand hygiene that can be used for residents or staff, on monitoring residents, and you know, keeping COVID-19 out. And a nice one on PPE as well. Okay, next slide. I think that's all I have. Oh, what can you do by next Wednesday? So again, we're always looking at evaluating readiness. So do you have the ability to isolate? And do you have contact and droplet precaution policies? And do you have signage? Are you ready to go if you have a case? And then evaluating your source control for residents and staff. And I know there's been a lot of activity in chat I have not looked at yet, but just looking at your universal source control and distancing in common areas of residents and staff. And I kind of point out again that break room that can be problematic for staff. So consider these things when as you're preparing, or if you are in the situation, how you can improve. Next slide. Okay, polling questions, Lisa. Okay, okay, it's the same 2 questions we had in the beginning. Okay, great. Is that the same question, Lisa?
Yeah, they're both the same. As far as, oh wait, that's number 1, sorry. The next one. Basically, it's not letting me pull up polling 2 for some weird reason. It only keeps pulling up polling 1 when I try to select polling 2. But the question was, how can COVID-19 disease be spread between people? And the options were by droplets in the air that are exhausted by an infected person and inhaled by others, or by touching surfaces with infectious virus on them and then touching your eyes, nose, or mouth, or both. And maybe they can respond in chat since we can't pull up the polling.
So I actually think the other question was on the time frame between exposure and symptoms. But that's okay. If we can get that at some point, that's fine. But we can certainly, we've got a lot going on in chat, so we can turn to that. There we go. There it is.
For some reason, it was showing backwards. I don't know why this time.
Okay, great. And that's correct, 2 to 14 days. So you're not going to show symptoms right away, but and it can take a long time, up to 14 days. Great. Let's look at chat, or if anyone has any questions they'd like to ask live. Lisa, do we have the raising hand?
So I'll go ahead and tell folks how they can enter any questions into chat. Of course, there's been a lot of chat going on, so if you have a comment or question that you'd like to type into chat, you can certainly do so. And again, when you do that, please chat to all panelists and attendees so everyone can see your comments. There's also an opportunity when we do some question and answer. If you go into the participant selection at the bottom of your screen, and there is an opportunity at the very bottom where you see all of our participants to click on these 3 little dots, and there is a selection to raise your hand. So if you have a lengthier question, you don't want to make your fingers tired and typing all of it out, please go ahead and use that feature and we would be glad to unmute you and allow you to share. While we are letting you all think of your comments, I'm going to actually pose to our panelists, which include Dr. Ellen Nakashima and Ali Spangler, to be able to maybe share a couple of comments on their end. So I'm going to start with Dr. Nakashima. Is there any comments that you have, Dr. Nakashima, or any announcements?
I'm wondering, can you hear me?
Yes. Mm-hmm.
Okay, good. Thank you for that great presentation. I really liked a couple of things that you showed that were really important. One was that figure at the end there where you showed the multiplicative effect of how infection spreads, and then even if your intervention is only 50% effective, how much of an impact that has. I think people don't understand that. So, and I just wanted to give an example that in the state of Utah, you know, we had, many of you know, in July, mid-July, really some high cases per day rates. We got up to like 700 cases, 800 cases one day, but then the average is around 600 cases per day. And then Salt Lake County put in an ordinance to do masking. And the we know from we do these informal surveys in our group where we just whenever we go anywhere, we count like the number of people in a store, for example, and then see what percentage of those people were masked, and then we report that to this person that's collecting the data here, and he kind of just keeps tabs of that. But it was pretty remarkable. It went from being around 23% up to about 60% very shortly after that ordinance went in place. And what was really even more remarkable about that was that our cases per day just plummeted after that. And you know, that's I think illustrated by that graphic you showed, that even though masking isn't percent, and even though we didn't get 100% of people to do masking, it was very effective in making that number of cases per day come down pretty significantly. So I think when people say, well, it really doesn't work and whatever, that's not true. It really does work, and it really is pretty effective. So I just wanted to make that comment.
Okay, thank you, Dr. Nakashima. And I wanted to just open it up for Ali. Is there any comments that you have or any announcements to share before we go to Q&A?
No, I don't have anything. This was a great presentation, and we're happy to help and assist and answer any questions further as well. So if you need anything, feel free. I'll put my information in the chat box, and we're happy to help and be a resource. But this was a great presentation. Thank you.
Awesome. Thank you, Ali. Okay. We did have a couple of comments and questions in chat, so I want to just verify what we will send out by tomorrow afternoon. Our previous recording for the kickoff that we had last week, and also for this session. So if you had people that missed the session and you want to share it with them, we will, have a recorded version of that, plus our risk assessment tools that we discussed last time, and materials from today. So we'll be sending that out tomorrow afternoon to everybody. So a couple of questions. I'm going to kind of start from and move around in them. Somebody had asked, who exactly is considered essential? We are worried about allowing all outside providers in. We want to minimize outside exposure, but many residents are demanding hairstylists, aides from home health hospice. What do you all do? So,
Well, this is Alan Nakashima. I also want to hear from Allie on this. So essential people, obviously, that's a judgment call. I think that certainly people that are providing specific medical care that need to come in to do specific care provision, you obviously need to have those people coming in. I think that hospice is an interesting one. I think that many of our older people are in hospice care, and it really is helpful to have the care, there's these hospice caregivers that come in to help with the family and the patient to deal with end-of-life types of issues. And so I actually think that is pretty essential, because I had a 99-year-old father that I took care of and who recently passed, and really I thought they were very helpful for us to make sure that we had everything in order for caring for him for the end of life days. So yeah, but I think it is a judgment. Does a hairdresser need to come in? Yeah, probably not. But then that depends on who you are. You may really want that. But there are some safer options. I think that it depends on, that's why I wanted Allie to chime in here, because assisted living people are a little bit more mobile than our skilled nursing or nursing patients. And so they could go to a hairdresser. What would you say about doing that if the hairdresser had 100% a masking policy in their salon, and then they could actually and rather than them coming into the facility, have the person go out to the hairdresser. I don't know how safe is that? Do they need to be in quarantine when they come back in again? I mean, those are kind of issues that people have to think about. I think that though, as this epidemic has gone on for so long, I mean, can you imagine somebody not getting their hair done for 4 months or 5 months? That's what this situation is like. And so I get it when people say, what is essential? So anyway, Allie, do you have any comments about that?
Yeah, definitely. I agree and echo what you say. I mean, I think it's so important to have your policies and procedures in your facility on what you're going to deem essential. And when you're considering things like, your palliative care, your hospice or home health coming in, what, is that an essential service? Can you do it? But what are they doing? Are they going to other facilities? Can that company assign just one staff member that only comes to your facility, so you're limiting that exposure? I think there's some ways you can do it smart and keep up your policies while still providing that care for that patient if that's something that is essential and you're not able to do there. But I mean, again, I agree with you, Dr. Nakashima, on the hairdressers. If you're deeming it essential, have those policies and procedures in place, and just make sure that you've got really great infection control program, but just really determine, is it essential and what is needed for the care of that patient.
great. Thank you, Dr. Nakashima and Allie. And I'm chuckling at some of the chat. We had somebody say that they're now a hairdresser, Walmart shopper, and manicurist. And so we've become jack of all trades in trying to manage infection and in a safe way. So there were a couple of questions about masking and access because, of supply chain concerns, and also issues on glove and mask supplies, and a couple of comments about where people have found their access to supplies, which is great. I'm wondering, again, Dr. Nakashima or Ali, if you have any thoughts on where people could go to if they have those concerns with the supply chain and what's been working locally or on the state level.
Yeah, I think your best bet is working with your local health department and your regional coalitions. They have supplies that they're getting and are able to assist long-term care. So I can send you that, Shannon, the list so that you could forward that out to this group, and they'll have that contact information. But they're a great resource and have supplies that you might not be able to get and can help get you through until your supply chain is able to be repaired.
That would be great, and we can send that out with our next invitation to folks so that they have that information. We did have a question about whether face shields are kind of able to be used to replace the mask, and I think that was answered in chat by some folks, but Dr. Nakashima, did you want to weigh in on that?
Yeah, this has been especially a controversial issue because of school opening. You know, obviously people want to see each other at school, and for certain kids, it's really important for them to be able to, for example, if they were deaf children, they need to be able to lip read and all of those things. So, but truly, I think from a scientific physiologic standpoint, it doesn't prevent the same way that masking does. The point of masking and that cloth or the surgical mask type of covering is to contain those respiratory droplets inside of the mask so they don't get out into the air. Reduce that number of those droplets getting out into the air. And I just don't think a face shield is going to do that very effectively. I think it's going to, you know, even when you don't wear a mask very well and it comes out around the sides, it's not very effective. But, you know, with a face shield, I mean, you don't have any, you know, you have completely open from the bottom and the top. So I don't think that that is going to really do the same thing.
Okay, thank you for sharing. We had a question on, or kind of a comment on just trying to, people wanting things to return to normal, and I think we can all relate to that feeling. And so Brooke had shared some things that she had done with a person that loves to fish, and, you know, some alternatives to giving them that experience. And it's very difficult for people to understand, and people have a desire to kind of get back to normal. And I just wanted to use that as a segue to share a resource that just came our way this morning from the University of Utah and the Department of Health, which was something called Conversation Cafes. And in the time, I won't show it to you on my screen, but we'll send you the flyer out in the resources. This was something that basically, it looks like something that you could share with your activity staff. It's a Zoom meeting that's happening August 12th, August 19th, and August 29th in the afternoon. One session is about music of the 50s. Another session looks about to share the huge selection of online resources for residents. And then there's kind of an at-home traveler virtual expedition. So we'll make sure we get that out to folks, but I just wanted to share that as a resource. So Dr. Nakashima had shared the link to current assisted living visits and guidance, which is in chat, and we can make sure that we send that as well. We are a little over, so I want to respect all of your time. From our panelists, do we have any kind of final comments to tie things up?
Well, no, but just really appreciate all the facilities out there that are really doing a great job keeping their residents safe. And it's a lot to keep up with. It's a lot to learn. There's changes coming every day. And we really appreciate the dedication you have to your patients and residents in the facilities. Thank you.
Wonderful. Thank you guys. Thank you everybody for joining us today. We're going to have the session next week, so look for our invitation, which will be coming out by tomorrow afternoon. And please share with anybody on your team or any colleagues that you think might be interested in joining. And this concludes the Infection Prevention Collaborative webinar for today. Thank you very much for attending, and we look forward to seeing you next week.